Welcome to our first interactive speaker BME seminar of the BME seminar series. As you know that the BME seminar is a unique feature of our new graduate program in biomedical engineering. It runs on a bi-weekly basis, and its structure is that we have, once per month, we have one student presentation and also one invited speaker presentation in order to provide exposure to a wide variety of research areas related to BME. In academia, our job is to educate and to do research. And we know that our research can bring us money, but we don't do it for money. We know that our research can bring us fame. We don't do it for fame either. We do it because we are passionate about the science and research, and we enjoy it. And also we do it because humanity needs us. My goal has been to invite the exemplary researchers, scientists in the world in order to provide exposure and inspire the next generation of the students and researchers in the world to see the mindset of the science and research. It is impossible to study lung diseases, in particular emphysema, which is a chronic obstructive pulmonary disease, and not to learn or read or hear about Dr. Hogg. The pathological changes in patients with COPD usually occur in 4 different compartments of the lung, which is quite complex. But it was until 1968, in the paper that Dr. Hogg published with his mentor, Peter Malcolm, in Montreal, that revolutionized the field of investigating the pathology of the emphysema. He said the focus of pathology of emphysema should be on the smallest airway of the lung periphery, not on the larger airways. And the substantial research, groundbreaking research that followed after this discovery, either by Dr. Hogg and his teams or other investigators, they all verified his original hypotheses. And they have advanced our knowledge of the lung and pathology of emphysema, COPD, asthma, and harmful effect of smoking and pollution. It is indeed my pleasure, my great honor to say that our first invited speaker for BME cellular facilities is Dr. James Hogg, who is considered as the most eminent pathologist in the world. Although he is extremely humble, and but he is considered by many of colleagues and researchers as the most eminent pulmonologist. I have been privileged to know him through the small group conference called Flow Volume Underboard, and in person, and but it was until last time in the airplane when by chance we were sitting next to each other, I learned life stories of Dr. Hogg, and that was the moment that I thought, aha, I found my best first speaker for the BME seminars. Then I invited Dr. Hogg at that time, and he kindly accepted. Jim was born in Misericordia Hospital in Winnipeg. After all, Winnipeg has been the house for many distinguished researchers in the world, like Dr. Newman Stevens, who said he would be here. He's probably on his way. Like Nick Antonison or Dr. Maggie Younes and Jim Hogg. Jim received his bachelor's and medical degree from U of M in Winnipeg in 1963, joined Navy and did preliminary research in the Institute of Aviation Medicine in Toronto for 3 years. After that, he did his master and PhD in McGill, and following the graduation of his PhD, in 1969. Okay? He went to Boston to do residency, and then was recruited by McGill as a professor in the department, which was promoted to the Miranda Fraser Professor of Technology in McGill in 1975. He was recruited by UBC in 1977, where he collaborated with Dr. Peter Perry and establishing the UBC Pulmonary Research Lab at St. Paul Hospital. Following his official retirement in year 2000 at UBC, Dr. Hogg still continued to pursue an active research on obstructive lung diseases at St. Paul UBC. In 2003, the lab was named the James Hogg Eye Capture Center for Cardiovascular and Pulmonary Research in his honor. He was also elected a Fellow of the Royal Society of Canada in 1992, appointed an Officer of the Order of Canada by Governor General of Canada in 2005, and in 2010 he received the Canadian Medical Hall of Fame, which is the most prestigious award. He has published more than 300 peer-reviewed papers, which one of his papers has more than 1,600 citations, and he has contributed to more than 20 books, chapters, and reviews on pulmonary diseases. Please join me to welcome Dr. James Hogg.
Well, thank you very much, Sarah, for that very generous introduction. It's a pleasure for me to be here. It's almost 40 years, I think, since I've been on the campus. I was back to Manitoba in July last year for our 50th, can you believe it, anniversary of our graduating class in medicine. So I think the University of Manitoba is a great place to get an education. I think that the basic schools here are very strong, and that we're all sort of been very privileged to have, those of us who have been here and graduated have been very privileged indeed. Now, I'm going to stop all of that nonsense and talk about the human lung. And this is a perfectly normal lung from a person who was unfortunately killed in a motorcycle accident. And a couple of things that I'd like you to notice is here's the main stem bronchus, and it's a highly branching tree. And you can see that as you go down to get to the distal branches, you can go by either a very long pathway with a lot of branches in it, or you can go by a very short pathway to short paths to get to the terminal bronchioles. And this is some real data on that, provided by Horsfield and Cumming, who worked in England. And this shows the number of divisions, just as this is laboriously counted from a cast, so that you can get to the lobular branches of the lung, and I'll tell you what I mean by that in just a minute, in as few as 8 generations of branching, or as many as 24, depending on how fast, which pathway you follow, and the average is about 15. Now, if you think of the consequences of that, in looking at the distribution of airway size, this is data again from a cast from Dr. Weibel, who's a Swiss anatomist, who's very, very famous. But it becomes obvious from what I've just said that if you took any particular generation of branching, there would be airways of different size. So if you start here with the 4mm airways, here in the blue, you sort of run out of those by about the 7th generation. Or if you start here with the 2mm airways, they begin at the 4th generation, and they're gone by the time you get to the 13th generation, and there's still several more generations to go, about 6 or 7. So that means that the airway size is, and generations are all sort of normally distributed, because if you follow these out to even smaller and smaller airways, because there's fewer and fewer branches that go out that far, you can see how this would come in a more or less normally distributed way. Now, the anatomy of the lung lobule is is illustrated here from a bronchogram, and I think this is the simplest way to think of it. If you come down here, there's branches that occur roughly every centimeter, and then you're suddenly into this structure where the branches are clustered only millimeters apart. And if you, that was an observation that was made by Lynn Reed, a pathologist who worked in London in the 1950s and finished her career at Boston and Harvard. Now, this is a lung not from the same person, but this is a lung that's been donated for research by a person that's had to have a lung transplant because they had chronic obstructive lung disease of a very severe variety. So that the only option for them was to have a lung transplant, and they usually have to wait on the transplant list for a long time. And during that time, they're approached. We're obviously not allowed to approach them because we might influence them in some way or be perceived to have some, and ask if they'll donate the lung that's coming out for research. And it's interesting to know that about 95% of the people who are asked willingly donate their lungs, say they've had enough trouble with them and they're glad to see the end of them. But this lung has been inflated with air and then frozen rapidly by surrounding it in liquid nitrogen fumes, so that you're left with a solid organ. And Miller, another anatomist, he described, you can see these sort of little outlines here that I've shown in highly magnified areas here. And he called this a lung lobule and illustrated it here in this dried specimen, where you can see the terminal bronchioles here breaking into respiratory bronchioles. So this is the lobule according to Miller, which is anatomic and surrounded by the structure, but they're actually talking about exactly the same structure. Now, just to show that at a slightly higher magnification, because this is very important in terms of a disease to understand the basic anatomy, we'll move on to the studies that were referred to earlier, and this is a study that I was involved with Peter Macklem many years ago, and it's that same lung that I showed you, where we put this catheter in a retrograde fashion. And you can see it's wedged into this airway, and it's got in by, you put in first a very large plastic tube that would, this is post-mortem lung, a large plastic tube that would wedge there. And then you thread a piano wire through that, which cuts through the airway. Pardon me, I hit the wrong button here. I'll just go back. You wedge it, the piano wire, so you push that through the pleural surface, and you take out the first catheter, and you hook up. Oops, I can't get the wrong thing. I'm sorry. You push this end of the catheter onto the piano wire and just pull. And that gives you the opportunity to measure the pressure drop from the opening of the airway down to this airway. Here you're actually measuring a side pressure, something farther up. It gives you the opportunity to partition the resistance between, and show where the resistance was. And until Macklem and his mentor Mead at Harvard had done this first in animals, it was always thought that the peripheral airways were the were the airways with the highest resistance, presumably because they were small. The engineers would smell a rat with that in a minute, but doctors believed that for many years, until this fundamental observation by Macklem and Mead. And then I had the opportunity to look at this in some normal lungs and in some lungs that had chronic obstructive lung disease. So we showed that the resistance in airways less than 2 millimeters in diameter was very low in the normal lung, but it increased 4 to 40 times in people with chronic obstructive lung disease. And these weren't people who necessarily died of their chronic lung disease. They weren't that kind of person at all. They were people that died not having, at least not thinking they had lung disease, and very often they have severe chronic obstructive lung disease. Now, it's a disease we know now from population-based studies that are being done across Canada that, you can have sort of mid-range chronic obstructive lung disease, and if they come in and see a doctor, and the doctor sees them and makes the right measurements, they make the diagnosis right away. But if they don't, it's amazing how sick they can get physiologically without ever recognizing it. And that's because we have a huge reserve in lung function. Whereas people who are getting older, and sometimes they might find they're short of breath, they might find they can't do things that they ordinarily can do, but they sort of think they're getting old. They think that there's something, you know, there's the denial thing, so that they can go on. So we find some people who have really quite severe, there's 4 sort of standards on a gold classification, and you can get up to sort of severe disease and keep denying you have symptoms. But it's really, really that way. And the physiology of that is really sort of interesting. You know, all of the engineers will certainly recognize that the resistance of the individual airways is proportional to the lumen raised to the 4th power. But in a semi-dichotomous branching system, and the electronic circuits are the best examples, of course, because they're arranged in parallel, the resistance gets less as you go towards the periphery. And it was easier to explain that by narrowing, because, you know, if you knock out half the small airways, they'll only double their resistance. And if it only take up 10% of the total resistance in the first place, you can lose a lot of airways and still not know that you've got much of an increase in airway resistance. But we never thought at that time that they could ever lose the number that you'd have to lose in order to get the 4 to 40-fold increase in resistance that we measured. So we thought it was mainly narrowing in those, and we couldn't count the airways anyways, because the only way to count airways in those days was to make a cast and actually physically count them. So the technique of micro-CT is not really a new technology at all. It's the same technology that was invented for CT, but it has a huge advantage that you take the detectors and you scrunch them, all of those voxels, down into a very narrow area so you can get a lot more magnification. And then you can use levels of radiation that you couldn't begin to use on living humans, because they would be damaging to the person. But you can do it on specimens. So in these air-filled lungs, frozen lungs, we cut the lungs after they were frozen. We keep everything frozen on dry ice and cut them into vertical slices like this. And then we'll take one of those slices, which you can see here, and we can sample them, and we can use those samples and fix them in a way that allows us to do micro-CT on the sample. So then if we get a properly based sample of the lung, and we can count the number of terminal bronchioles, and I'll show you how we do this in a minute. It's really quite simple work. You can calculate the number that's in each one of those cores and get the average number per unit of volume of lung, and multiply that from the total volume of the lung, which you can compute from the CT scan of the specimen, which we do before we freeze it. And most of all, you can take these samples and place them on the CT scan so you know where they are. And then you can take one of these samples, just an example here, and at minus 80 degrees, and we use pure acetone as a fixative, which has a freezing point of minus 93. Now that's not a very good fixative, but if you add 1% glutaraldehyde to it, you have a really good fixative, and you can fix the whole piece of tissue at minus 80 degrees. The lung will initially float because it's full of air, but it gradually picks up the liquid by capillary action. And within leaving it in the freezer overnight, it'll be frozen solid in the morning. And it maintains its shape quite well because glutaraldehyde is a cross-linking fixative, which keeps it from the elastic properties. If you just took that piece out and left it warm up, it would collapse down to something really miserable here. But here it maintains the same shape, and then you post-fix it in osmium to give it a little more density, and critically point dry it and examine it with a micro-CT scan. And the micro-CT allows you to examine this across, through that whole core, and get sort of resolutions that look like this. So you can see the terminal airways and see them exactly. And you can do that very quickly through this whole stack of, in the micro-CT scan, something that would be an enormous undertaking to do anatomically. Now, this shows this at a little higher magnification, and you can see this terminal bronchiole, which is the last bronchiole that has no alveoli on it, and it's breaking into respiratory bronchioles, which you can see alveoli opening up. But you can see it gets very narrow here, and you'd be stuck with that if you got it on histology. But by using the software that's available for the micro-CT, you can adjust that so you can see it in a true longitudinal section, and you can see this terminal bronchiole, and you can see the alveoli beginning to open here. So you know anatomically exactly where you are. If you were dependent on the narrowing of the airways, you really can't count the airways that way because they all narrow, and you might end up with more narrow airways than there really should be. So you have to have an anatomic landmark. And then you can use the same sort of software to look at it in cross-section and calculate the diameters and so on. So to make a long story short, we did that. So this is the overall anatomy that we're looking at. Those are those branches that we looked at. We come down to the terminal bronchiole that I showed you. This transition, shown rather markedly here, in terms of the alveoli beginning to open up. Then you go farther into respiratory bronchioles, and you finally get to the alveolar ducts where there's no bronchial epithelium, they're just clusters of ducts, and then the ducts end blindly as sacs. And these are the, over 50 years, the people that have counted the number of terminal bronchioles from a cast. And so this Rohrer in 1915 thought there was 30,000, and he is the one who was responsible for thinking they were narrow in the normal lung because he didn't have a properly inflated lung, and they looked abnormally narrow, but besides he didn't count them all. This was another paper from Germany that thought there was 54,000. This was Weibel, 66,000, and then Horsfield and Cumming, who the lobular airways are just the ones inside the lobule that I managed, so they missed the final two branches and probably why their number was lower, but they found from those four casts, if you take the average, it's about 44,500. Now, if you look at the micro-CT on the four lungs that we've done, we found, satisfyingly that there was 44,510 in our group, which is about as good as you do as I have ever done in getting experimental work to fit what you predicted it might look like. But in sharp contrast, when you start, here's just some more of the normal lung. Here's the airway diameter here on a logarithmic scale. Here's what we call a bronchi, which just means they have cartilage in their walls. And here are the airways, which we call bronchioles, and respiratory bronchioles are explained easier, but the bronchioles have no cartilage in their wall. And when we plot our data on the measurements that Weibel made, his very elegant work that he did, we found that our data fit pretty well in terms of the diameter of the cross-sectional area. And we look at the total cross-sectional area of all of the terminal bronchioles. Here are all of the airways. This is Weibel's famous data. And when you calculate using his data, here we are coming against generation, and here's the total cross-sectional area, and you can see it's rapidly increasing. And that was one of the reasons why, one of the major reasons why the resistance goes down, and it's a critically important reason for how we all breathe. Now, if we you're all sitting there quietly, taking in our tidal breaths, and you're taking about 500 ml into about 3 liters of gas volume. And as all of the engineers will appreciate, that the bulk flow of this gas gets less and less and less as this cross-sectional area gets here, but you're entering an area where there's a very wide cross-sectional area, and it's very good for diffusion. So we can exchange gas largely because we have this very large area for the gas to fuse across. The surface area of the whole lung is roughly the size of a singles tennis court. Then if you're moving gas into the airway portion of that, you're very, very dependent on the diffusion of gas and the rapidity of the diffusion of the oxygen out and the CO2 back for us to maintain ordinary gas exchange. But you can see if we breathe particles, And believe me, there is no better way to dose your lungs with particles than to light a cigarette, take a puff, and inhale it deep into your lung, and hold your inhale there at the top, so you're absorbing the nicotine, and it's getting to your nicotine receptors, and it feels really good. But the particles that are in the cigarette smoke, especially the particles that are less than a micrometer in diameter, they're carried out with the bulk flow. But since they don't diffuse nearly as well as the gases, that's why we think that these airways in this area get a terrific dose of those toxic particles and gases. And it doesn't matter whether they come from a cigarette. Fortunately, you don't have much problem with air pollution in Winnipeg. It's a very clean city. The air is terrifically clean. But if you're walking down busy streets, especially the ones with high buildings on either side, and there's a lot of traffic going by, the particles that are there in the street that you're walking along to do that can be considerable. And so there's, and especially the diesel particles, which we're only really beginning to learn about it, and what happens to them in the lung. But it's a problem that really needs the attention of engineers to solve, because in order to get the proper levels for our Clean Air Acts and one thing and another, of course the easiest thing for smoking is to stop smoking, but there's lots of interesting work to do about that. Now let's go back to our ordinary lung here, and then look, this is a lung that's affected by centrilobular emphysema. And I think you can see the most classic description is you can see these little balls hanging off the end of the air. It looks like sort of Christmas tree decorations hanging from a tree. And you can see them all over the lung. They tend to be worse up in the upper regions, but they've lost their fine taper down, and they form these things. Now, if we look at that here again, and this is now a lung that's affected by centrilobular emphysema. These little bally things, if we'll look at it at higher magnification, are probably these little things that you can see about here, or about that size. And what happens is they start in one of those lobules we described, in a very discrete portion of it. Then they gradually spread to the whole lobule, and then they take the entire lobule out, and then several of the lobules will coalesce, and you finally end up with holes in your lung. This is a slice of lung that is 2 centimeters thick, and you can see right through it. And once your lungs get to this stage, they won't come back. They'll only get progressively worse. And it makes gas exchange a very tough business for people. Not when they're at rest, but they'll notice it especially when they exercise. Now, just do a little breathing maneuver with me. You're quietly breathing. You can breathe a long way out. You keep going down from where you breathed in, and you can breathe a long way in. Now, go up to the very top of your lung. Just try it for a minute. Up to the very top. And breathe up there. Does it feel comfortable? It doesn't. How do you feel? I won't belabor this, but most people, when they come to the doctor and say, I feel tight this morning, doctor. Can't breathe, I'm feeling tight. And the chest feels tight. And the reason is they have a lot of gas in their lung that they can't get out. And they're up on that portion of the pressure volume curve of their lung and their chest wall, which makes it very difficult for the respiratory muscles to move the lungs and move the gas in and out. So not only is it a difficult thing to breathe, but the gas exchange is bad because their airways are sick and their parenchyma is partly destroyed, so that they're not exchanging gas very well at all. And this happens, asthmatics get this in spades when they get symptoms of it being asthmatic, but it goes away. It's reversed because it's caused initially by a constriction of the muscle in the airways, which traps the gas, and when you relax the muscle, it allows the airways to empty again. But in this disease, it doesn't happen. It doesn't get better because the airways are destroyed. Now, here we are back in this lobule again, and this is the lobule. Here are the terminal bronchioles, these little things right out at the end, not very well visualized. And here's what we call the primary lesion of centrilobular emphysema. And this is beyond a single terminal bronchiole, and it begins in the proximal respiratory bronchiole. And at least it's my opinion, not everyone agrees with me, but this is the area that gets devastated with particles when you smoke cigarettes and when you breathe it in a dusty environment. So, and then that's against a single terminal bronchiole, but when you rot out the entire center of the whole lobule, what happens is that the single primary lesion, as we call it, spreads and to many primary lesions, and they coalesce to take out the center of the lobule in that thing. And then we're left with this structure as we saw before. Now, can we count the number of terminal bronchioles per cross-section and calculate the cross-sectional area by using micro-CT? And this is the problem that we set ourselves a few years ago. And this is the data, to cut a long story short. This work was done by John McDonough, who was a graduate student with me at the time, who's now a postdoc over in London, and would be a good young person for people to keep their eye on. But what John found here in these control lungs, this is now just one lung, so instead of having 44,000, we have 22,000. That was how many terminal bronchioles there were. But when we looked at it in the centrilobular form of emphysema, they were down to this number, so it's a terrific reduction. So for the first time, we realized that you can lose this many airways to cause the resistance to go up to that level, and that loss of airways, in addition to the narrowing of the ones that are left, is a very important part of this disease. Now, this is the commonest genetic cause of emphysema, and it's a different form of emphysema. We don't have to go into it. The destruction is just a little bit different, but it's due to alpha-1 antitrypsin deficiency. Now, we all have alpha-1 antitrypsin circulating in our blood, and we have to have it because it's the major inhibitor for neutrophil elastase. Now, if all of the neutrophils, the white blood cells in our blood, were to suddenly release their elastase all at once, people have actually done this calculation. If that were to happen to me right now, I would sort of disappear into a spot, on the floor, a little spot of grease, because they're very powerful enzymes and we carry a lot of them. So it's very important to have this inhibitor. And when you don't get it, and when you don't inherit the ability to get it, you may do fine, actually, but especially if you smoke, you're very susceptible to getting disease. And they're reduced them to about 25% of the control values. And when we looked at the total cross-sectional area of the terminal bronchioles, that's what we found. It was in agreement with Libel's data, and these are the sort of measly numbers that you come up with in these people. Now, these are people who are very sick, right? This is their last chance to get a transplant, and believe me, they wouldn't do it and go through if it didn't work. And I've got a neighbor of mine on Bowen Island where I have a place, and she's had a lung transplant for another kind of disease, and she's gone from a bed and chair existence, which is somebody who has to make it to a bed and a chair, have those nasal prongs in their nose, can't get up and walk, can't sort of dress themselves, can't get to the bathroom, all of that kind of stuff. So that's the kind of existence she had, and she's now, she walks up, if you've been on Bowen Island, there's some very steep hills, and the hill up to our place is pretty steep, and it's about a 4-kilometer walk. And I do that with her and her husband, twice a week when we're out there. And so you can get a fantastic result when they work. They don't always work, though. You've got to be honest about that. Now the question is, when do you lose them? So here's a measurement of emphysema, which is we call the mean linear intercept. It's just a way of measuring how big the alveoli are. And this is the normal distribution. And this is what happens in centrilobular emphysema and the other form of emphysema, is it's shifted way down here. There's big holes, there aren't very many of them, but there's a lot of these small holes. But there are portions that are in the normal area of the lung that even if we have that lung out in front of us and looking at it straight, we can't tell there's any emphysema there at all. And we make the measurements, there's no emphysema. This arrow is the 95% confidence limit. So that we ask the question, what happens to the airways in this part of the lung, where there isn't any emphysema? And what we found is this, is that here's the control values. There's about 6 of these terminal bronchioles per ml of lung tissue. And here we are in the centrilobular emphysema, and this is below this 95% confidence limit. There's no emphysema at all, and you've already lost that many airways. So the point is here that you've begun to lose your airways before any emphysema develops. That's a bit of a new concept for us. We always thought that the airway disease was secondary to the emphysema. We now know quite definitely that it isn't. And this is a number that's worth remembering because that's 1,000 micrometers, a millimeter, and that's the spatial resolution of a clinical CT scan. If you go for a clinical CT scan, a radiologist who's sharp can pick up those areas and call them emphysemas. They're very small. And we know now that those airways are starting to lose in those areas. And it's an important issue, and the question is, when on earth does it happen? And we've got a lot of experiments that are just getting underway to ask that. Because it happens very early in life, then you know that it's a very important issue because you've got to do something before they're gone. Once the airways are gone, very difficult to grow anything new in the lung. Nobody's really interested in even playing with the drugs that will grow new things in case in heavy smokers who are susceptible to cancer that you might grow something that you really don't want in those lungs. So that you have to do something before it happens, and there's a lot of effort going into that. Now, here's the data we just saw, and the question is what happens to the walls of the airways, and what happens to the rest of the airways, and these are the survivors that have thickened walls. Now, you can't believe how long that we puzzled that we looked through our microscopes and we could see thick-walled airways right next to emphysematous destruction. And we thought, you know, there must be two processes going on, one that thickens the walls and one that destroys the tissue. But now we know from these very simple experiments, the advance here is nothing intellectual. The advance is the technology of the micro-CT that allowed us to do it. When you get this, the airways that are left are the ones that are thick. So you're losing lots of airways, and the ones that you have left have thickened walls because they've attempted to sort of protect themselves by thickening. Now, if we look at this in another way, here's that same alveolus we looked at before. This is scanning electron microscopy. That you can look at these same airways in a different way, sort of coat the surface, and then you remove the coat, and you're really looking sort of at a shadow of the surface. But these are the sort of pictures you get, and this is a respiratory bronchiole here that you can begin to see these openings. Now, these are openings in here, these big things. We used to think they're alveolar openings, but they open into sort of clusters of things. And here's true alveoli that are over here. And if you look at something like this, at a little higher magnification, it looks like that. So that's an alveolus. Look through this thing. Some of this is artifact. But what you get in normal people is these small pores of cone. And there's a lot of wonder about what these do, but they're very important because if you plug up an airway, you don't want that part of the lung to collapse. So that these structures are the ability to have the gas at least equalize in pressure across it, so that you don't get collapse. And this is a control. We never call our subjects, the subjects that we have for our control lungs are people who have donated their lungs for a transplant. But if we don't find a recipient within a certain time frame, then they can't use that lung because they know that the disaster happens if they use them when they're too late. So then the lung, through all of the donation procedures, is released for research. So we get a chance to do this research on what we call control lungs because we know they're not normal. These are 64-year-old people. This happens to be a non-smoker, and you can see clusters of these pores of cone there. Now, what happens, and this you can see them at a higher magnification. Now, I'm not going to belabor you with all of the things, but what happens in the early emphysema is that it begins by these things sort of coalescing, and the holes get bigger and bigger and bigger until the whole alveolar surface is gone, and then more of the alveolar surface is gone, and then more of the alveolar surface is gone. Now, how can you look at gas diffusion in the lung? Well, this is an image of people that have been imaged with hyperpolarized gas, and these were done by colleagues of mine who work at the University of Western Ontario, where they've got a very good MR facility, and they have a facility for making hyperpolarized gas. So this is something you don't have to worry the patient about giving them radiation to look at their lung. You can have them breathe in this gas and do MRI, so you could do it sort of every week, and it wouldn't, there would be no damage to the patient. And this first person here is, you can see, pretty homogeneous gas distribution. And then this is an ADC map, and the way that is caught, this is a apparent diffusion coefficient. And what they do is when they have the MR signal of the gas diffusion, they take sort of snaps of it every milliseconds apart, so you can measure the diffusion. And this heat map here tells you where the diffusion is getting really fast. Now when the holes get bigger, the diffusion gets better. So as the emphysema gets worse, you get better diffusion. Now this is a person in this next image, which has got heterogeneous gas distribution. But they've got an elevated ADC. That means it's, you know, and they've got a normal lung function. But if you, in this bottom one is a heterogeneous distribution in a person who's got gold 1 disease. And you can appreciate there's quite a few defects in diffusion. And that these areas with this yellow color, the diffusion is getting more rapid. So here's a person that has virtually a normal FEV1, which is the amount of air you can blow out if you try as hard as you can in 1 second. But yet, we know that they've got airway disease for other reasons. Now, the Helen Marshall, who's a young woman that works in Sheffield University, did this classic experiment and published it just last year. And this shows unequivocally that there has to be just diffusion of gas. Because what she asked these patients to do, who had these filling defects, is just to hold their breath and see what happened to the defect. So this is at 0 seconds, this is 1.3 seconds, and 5.8 seconds. And as we go down here, 19 seconds, 20 seconds, doesn't sound like much time to hold your breath, but if you're a person that's got this kind of disease in your lung, I think we couldn't ask them to hold their breath any longer than that, but you can certainly see that this gas is diffused and filled in this defect. So we don't know for sure that that's happening at a smaller level, but we think it's happening, and Marshall and her colleagues, and also the group in London, Ontario, are doing experiments now with people with mild disease, where they breathe in the gas, see the filling defects, and see if they fill up. Because that would be pretty good observations that there was collateral ventilation through there. So going back to this thing, here's our model of this disease that we talked about before. It starts in this, beyond the single terminal bronchiole, and it starts in the respiratory bronchioles that are proximal. So it's like there, they coalesce and you end up with a hole like that. So the electrical model that we have is very simplified because we're not sophisticated in this kind of work at all, but this is the sort of would be a pre-terminal bronchiole, and these would be 2 terminal bronchioles. And here would be the 2 compliances, which would represent the alveoli opening and closing, or open, expanding and contracting at the end. They don't open or close, they expand or contract. So what happens to this is a situation where here, we think the first thing that happens is we begin to lose the respiratory bronchioles, or terminal bronchioles rather, before the respiratory bronchioles. So that here is pretty normal lung that now no longer has a terminal bronchiole. You've just knocked it out. So that in order to get any gas at all, you have to be delivered from this bronchiole. And what happens is, our working hypothesis is that the emphysema forms really to drop that resistance and be able to ventilate this part of the lung. It's a savior maneuver that probably was designed to help us when we aspirate ball bearing or something that you can, into your lung that would block up one of these lungs. So that we think that the destruction in the centrilobular emphysema is occurring because of this. And the way we're trying to get at that is to do the technology like hyperpolarized gas to get some measurements of that. Now, what happens if you compare the micro-CT just to the histology? So this is what the histology of the lung looks like. You can now see the airways here, and you can see the vessels, and you can see smaller airways. And you can see the air, and you can see the rest of the tissue. Now, from the CT scan of the whole specimen, we can compute the whole lung and get gas volume. So that you can get all the voxels that fall on the scan, so you get the volume of the lung. You can measure their densities of the scan, and so you can get the weight of the lung, and you can compute the gas volume. And you can do the same thing with these tissue samples. But if you process them for histology, where you can see these, you can point count, use a technique that was really worked out by a geologist named Deficiency. And what Deficiency showed that it did the mathematics back in the 1800s was that if you took, say you were looking for gold, you got a sample of gold or a sample of rock, and you then examined the cut surface of the rock and point counted the fraction that was the ore you were interested in against the total rock, the total area, and then multiplied that by the reference volume, which is the volume of the whole rock, you'd get the amount of ore that was in the rock. And that's the technique that I've told geologists still use, only they have much nicer computers than they had back in the 18th century to do that. And that's essentially what we do here, is we get the total amount of that area that is taken up by tissue, and then we take the fraction of the area that is taken up by airways in that tissue, so we can get a volume fraction of the airways that is taken up by tissue. And when we do that, we can compute the volume fraction of the small airways for anything you like. Now, we can carry that on by doing, we don't like to fix the tissue because we want to do things that we can't fix the tissue on it. So we take these other cores of tissue and we vacuum embed them in a gun called OCT, which is optimal cutting temperature embedding media. It's the sort of goop that pathologists use to do frozen sections in the OR. And you do this, you warm them up sort of close to freezing temperature and vacuum embed it in that stuff, and then you rapidly freeze it on dry ice, and you can cut sections from it. And you can look at them histologically. So you can stain them just to see the sections. You can immunostain them, so you can look at a specific thing. And you can use a technique called laser capture microdissection to separate out the airways from the parenchyma and look at the gene expression on the airways against the parenchyma. And that's what we've been doing with ourselves for the last few years, and I'll just run across this data relatively quickly. Now, here this is the bronchiolar tissue, and there's the total volume of bronchiolar tissue, calculated in this way. And here is the sort of other tissue that we didn't stain for anything. This blue is for other collagen, and this is for collagen 3, and this is for collagen 1, and this yellow stuff here is the elastin, and then this red stuff is all of the inflammatory cells. So with the wonders of immunostaining, you can stain each one of these things, and then figure out that you can see here that if you take just the collagen, which is sort of from the green down here to the dark blue, you can see that before there's any emphysema at all, there's been tremendous remodeling of the collagen in the small airway. And you can see that stays, changes a little, and when you get down to the point where you can see this on a CT scan, or you can see the emphysema, you can see there's been tremendous remodeling of the collagen. The elastin's gone to nearly nothing, and this is essentially scar formation. Now, all of us have cut ourselves. You've fallen off a bicycle, you've done something to yourself, and you've got a scar that you can watch over the years. And it's red and angry at the start. First you coagulate the blood, which is a sort of damage control. And then as that clears away, the inflammatory cells migrate in, and then cells that are capable of producing collagen migrate in. And in a normal scar, the inflammatory cells begin to disappear as the scar is laid down. But in a chronic injury, it's hard to imagine a better persistent chronic injury than smoking 30 cigarettes a day for 40 years, which some of these people have done. So in that chronic injury, you not only get that persistent inflammation, but you get a complete remodeling of the scar. And it's not a normal scar, it's an abnormal scar, which we call fibrosis. And that's what happens, is you end up with a lot of fibrotic airways, that many of them have gone, that's why the total volume has gone so low, and that those that remain have thickened, scarred walls. And this is what happens in the parenchymal tissue, which is more or less the same thing. You can see here that this tremendous remodeling of the collagen that occurs, and the total volume of tissue doesn't come down quite so much at this relatively early stage of the disease. And you can look at don't bother about the names of these cells, but you can look at the volume fraction of cells that have migrated in with the stain. And you can see here's the CD8 cells, which are a very important component of the immune response, and they increase. And here's the alveolar eosinophils, which are, these are much smaller numbers. There's changes in the decimal points around here. There's very much fewer of these eosinophils, but they do get in there and do something. We're not really quite sure what. And this is if you look at the same sort of thing in the bronchiolar tissue. Now, you can look at macrophage infiltration. The macrophages are really the good guys, that when we breathe in the particles, these macrophages move around very quickly and pick them up. And they move them up to the mucociliary clearance, and it's rapidly moved out of the airways. When we did bronchograms, like I showed you, that's blowing finely particulate dust into the lungs, in animals, we once had an animal which we had a beautiful bronchogram on, and it was about 6 o'clock at night. Peter Macklin, who was my boss, said, let's go home and we'll put the animal back and we'll come and do the rest of this experiment in the morning. When we came back in the morning, all of that stuff that was in his airway was in his ball in his stomach. So if you're a healthy person, you can really clean out the bad stuff that you breathe in your lungs. But anyways, these macrophages, if you go from people that don't have any emphysema to people that have relatively mild emphysema, you can see a lot more of this red staining, which means that there's more macrophages. You get the same thing in the airways. Here's the airway epithelium. This is the lumen. And you can see there's not much red color. When you look over here, there's quite a lot of red color. And you can quantitate that. And here's the individual people, and the individual dots are the different samples. So that you can see here when the alveolar macrophages are relatively few, there's lots of surface area in the airways. When you get lots of alveolar macrophages, the surface area begins to fall down. So there's been theories about whether or not this is sort of more of the same. And if we just go through this quickly, again, if you look at these macrophages another way, and here is looking at the alveolar destruction against the natural log of the alveolar surface area. So when you've got lots of surface area, here, very little surface area, rather, you've got lots of macrophages. And when you've got lots of alveolar surface area, you don't have so many macrophages. So the macrophages are involved in destroying the tissue. And when you do the statistics, when you look at the airway wall thickness, the things that come up, this is a linear mixed effect model that we use. When you compare this, you see that the total bronchiolar collagen, the collagen 1, some of the macrophages, collagen 3, are all involved in this in the CD4 cells. But if you then look at the multivariate analysis, the thing that comes out as very strong in explaining most of the variants is the total bronchiolar collagen and the collagen 1, which is the scar tissue. So the airways, these thick-walled airways, are a scarred end of the process. It's like you, after you've had the scar there for several months, and it starts to look fibrotic, and when it's a year or so old, it looks quite fibrotic, and you never notice it anymore. And then here is what happens if you look at this, at the number of terminal bronchioles, the same thing. I'll just speed on here a bit. But when you get over to the alveolar surface, now we're dealing with B cells, CD4 cells, macrophages and a little bit of collagen 1. So it's a heavy inflammatory process. So that's more histological evidence for a process that begins in the airways and leaves this fibrotic wreckage behind in the airways as it spreads into the alveolar surface to start the emphysema's destruction. Now, if you then look at to something that is completely different, because what I just showed you tells you in very rough terms what happens to the remodeling of the collagen and elastin, and what happens to the inflammatory infiltrate. And along comes a technique like the second harmonic generation microscopy, and we have one of these things at our institute, and people who are very interested in inflammation and fibrosis use it quite a lot. And I was talking to Thomas Abraham, who's a PhD in optics, who runs this facility for us. And I said, Thomas, wouldn't it be wonderful if we could look at this under really cold conditions, so we could just take a piece of frozen lung, keep it frozen, not do anything else to it, and see where the collagen and elastin is in those lungs. And he said, well, that should be easy, because people who are interested in ceramics use this technology all the time at very low temperature. So he found a supplier that built him a frame. Here's exactly the pictures we've been looking at, but now we take this little bit of air-filled frozen tissue, or this core, and we cut a piece off it, and we mount it on the stage, which we can keep at minus 60 degrees, and then we look forward at it with this technique that allows you, I should have gone over the technique a little bit more, but when the laser beam goes through the first time, if you get it right, you can get the fluorescence of the collagen 1. And then when you get the second harmonic, which is the reflection of that beam, which gives you another sensing source, you can get the collagen 3. So and with the regular thing, without doing anything, you can get an image of the elastin. And if you look at this again, this is just a reminder that this is these holes here, these things going around them, that's collagen here that is around the mouth of an alveolus. And we wanted to see, and you see, that's where most of it is. That's where all the stress is in the system, is right at that area. And here is, you can look at the elastin here, and then you can merge the two images that allows you to look at the relationship of the collagen to the elastin. And I think you can see that it's sort of wrapped around it in a circle. And it makes perfect sense. Oh, we don't have something to rest here. But if you can think about, if you had pure elastic band, it would go up forever until the elastic band broke. But if you put collagen around it like that, like a piece of string that had a definite length, so its behavior would be easy to stretch it till you got to a certain point, and then very difficult to stretch it. You can see how the collagen would be protecting the elastin from being overstretched. So we think that this is how the lung is organized and how it is around the alveolar mouths, and that's what sort of breaks down. And this is just to take you through very briefly what happens. That's a normal area here, and here's what you've got still less than 1,000 microns, and you can see that things are getting a little hazy, and then how dense it gets, and how thick the walls get, and how disorganized things get. So that somehow that lovely, nice arrangement that you have for the arrangement of collagen and elastin breaks down terribly as the emphysema begins to form. And you can quantify that and get stuff. We did it this way. The other thing is that it's very helpful. I won't show you all the data. Is that you can now use a completely different technique than the histological one we looked at to try and get the same answer from the same tissue by doing this type of microscopy. Now, let's briefly just go through this. How am I doing for time? I don't want to go over time. So what? This is the natural history of how COPD works. This was a guy named Fletcher, dead now. So he was Sir Richard Fletcher, when he died, and a very distinguished physician. And he followed postal workers in London over many, many years, about 8 or 9 years. And he found that, to everyone's surprise, that if this is the disease getting more severe here, that there was this group of people which he called the susceptible minority. These were all, these are non-smokers. These are smokers who have quit, so they do get some recovery towards normal. And these are smokers who continue to smoke, who don't get emphysema. And we don't understand that completely. And this is the susceptible minority. So there's two ways you can look at the progression of the disease. You can take groups of people, and we were able to do this, that have different stages of the disease, and we could look at the progression of their disease and comparing one group to the next. Or you can take this group down here, who are the susceptible minority, and look at the progression within the individual lung. And that gives you a huge experimental advantage. And, you know, just summarizing, John showed that the micro-CT, that they were reduced in number before the emphysematous destruction began. You compare that to histology, we got a consistent result. And when we used the SHG CIVIT imaging, it gave us for the first time an idea about how the collagen and elastin were distributed in 3 dimensions in the lung. And it's something we hope to pursue. Now, finally, this is why we froze the lungs in the first place, is we wanted to look at genetics within the lung tissue. And if you freeze the lungs rapidly, especially when they're brought freshly out of the OR, you preserve the RNA. You know, your DNA lasts forever. Richard III's DNA lasted since whenever it was, and it's very tough stuff. But RNA only lasts very briefly because you've got thousands of enzymes that will destroy it, so you have to freeze it very rapidly and treat it properly. So that we were able to take one of these slices and take one of those cores that we looked at and look at the gene expression. Now, this was done really by our collaborators in Boston University, and Josh Campbell, this was his PhD thesis. And what he did is, here is you're going from the low LN, that is no emphysema, to severe LN. And he found a bunch of genes that went up in association with the emphysematous destruction. And he found an equal number of genes. The red is the high expression, here the green is the low, so he found an equal number of genes that went down. And he discovered sort of 127 genes that are significantly associated with regional emphysematous destruction, measured with micro-CT. So this is sort of a groundbreaking study that they've done, because it's for the first time allowed you to compare gene expression in tissue that's side by side with the gene that you where you measured the emphysematous destruction. Whereas before, people would take a piece of lung tissue that they get from somebody surgically or whatever, and then look at their FEV1 and relate gene expression to a measure of whole lung function. Now, surprisingly, we found many of the same genes that they found, and there was a certain number of genes that increased with expression enriched for the B cell signaling, and that's interesting to us because we found lots of B cells in this lung, and the decreased expression was enriched for genes associated with tissue repair, including TGF-beta and actin organization. And then there's a very clever connectivity map, which is part of bioinformatics. It's freeware on the internet, and you can use this to analyze data. And what it allows you to do is it's collected data from all over the world about what happens to gene expression in certain diseases when certain drugs are given. Now, some of this is animal data, some of this is cell data, some of it's human, some of it's animal. It's a bit of a mess, but they've got this thing. And anyways, you can feed your data into it and ask the question, is there a drug out there that will reverse this gene expression pattern? And what they found using this connectivity map is that this GHK, which is a tripeptide, which circulates in our blood bound to a protein, and is used as a common thing in things like shampoo for men who are losing their hair, and things that are related to cosmetic surgery when you want to heal things faster. And there's a pretty good take on this GHK that it might be beneficial. Unfortunately, when it was tried on a clinical trial, they picked diabetic ulcers. Now, diabetic ulcers are very hard to heal. And they picked diabetic ulcers as a clinical outcome, and it turned out that the bugs that were growing in the diabetic ulcers liked the GHK. So it failed in that clinical trial, and of course that finished all the investment in it, so it would probably never see the light of day as a drug. But since we've come out with this, I've had long-distance phone calls, wires, emails about people who have this disease who are quite willing to take this drug in some way, which of course I can't possibly recommend because I don't have the data. And then what different people have done that work in our group is taken that drug in tissue and cell culture and shown that you can reverse the effect. Things that will depress TGF-beta can be reversed by this drug. So this is just a start at looking at things, how you might search for a drug. And this is the final thing that I'm going to show is the laser capture data so that you can separate the airways from the surrounding parenchyma and just sort it out into other tissue. And then you can take just the airway wall thickening and look at the gene expression that's associated with that. And we find that the airway wall thickening is the one that's dominant for the TGF-beta, provides most of that signal, which again fits with the airway model. And a lot of these other things that are in this pathway for things that are going up are things that other people using animal models and so on have published about might be beneficial effect for some forms of emphysema. And then you can take the surrounding parenchyma and get this again. So you can separate out what's going on in the airways in the parenchyma. And this is not published yet. It's Julie Zeskan. This was her PhD thesis. And she's got her PhD thesis, but she hasn't really written up the stuff yet because she's had a couple of babies. They slowed her down a little. But anyways, we'll get it out in time. So that in general, this is what we think about this disease. It's a disease where you can measure lots of things by comparing people in different groups. You can get a whole lot of ability of information about taking people who are going to have lung transplant and looking at the disease. The tremendous advantage it gives you looking at gene expression is you're looking at the progression of disease in a single individual, so you are by definition on the same genetic background, and it makes the math of planning these experiments a little bit easier. I won't go through all that. I just thank all the people. This is where I live now in Vancouver. I love living in Winnipeg. I love living in Vancouver. This is Stanley Park. Many of you know about St. Paul's Hospital. This is where the cruise ships come in and out. And straight up Burrard Street up to about here where St. Paul's Hospital is. The nicest place in all of BC is Bowen Island. I have a little cabin that I like to go to that lives over there. And here's West Vancouver that you can see over there. And of course, it's a standard picture of Vancouver. Now, the people that have helped, starting with Pittsburgh, a number of people have helped with these experiments, particularly Bob Rogers, who came up to Vancouver and spent a sabbatical with us. And Joel Cooper is actually a Canadian who he would never claim that he invented the lung transplant, because he didn't. But I think everybody in the world today would give him credit for making it work. Well, he and I were residents together at Massachusetts General Hospital. He in surgery and I in pathology, and I got to know him then. And he's the surgeon that has provided most of the lungs for our study. And then he had a fight with his boss and moved to Philadelphia, where he's now the chief at Penn. And this radiologist, Warren Gefter, helped us understand micro-CT and realized that we could do these experiments. These are the people at Boston University, in particular Ava Spira, another Canadian, who went to medical school at McGill and did his residency in Toronto and then stayed down in Boston and is still there. Somebody should recruit him home. And then these are the people in Vancouver who helped me a lot. John McDonough did the micro-CT. Masa Suzuki, a postdoc from Japan, who did all of the histology and a lot of the laser capture. And Ren Yuen, who's a radiologist, and many other people who helped me there. And of course, the financial support that we've had, particularly from the NIH. and from the CIHR and the BC1 and some from industry as well. Thank you very much. I'd be glad to answer any of your questions. I hope I have all of your
Question? At the same time, I should say that since the food are here already and the smell is spread in the room, feel free to go and have some dinner later while you're asking questions.
Don't be shy.
I have questions, but are they for me?
Yes.
Do you have any clues about the people who are smokers and don't develop such high emphysema? Like you mentioned it briefly, but I don't know.
Well, I mean, that's the really important question. Just as important as why do these people get emphysema is why do the ones who've smoked just as much as these people.
Yeah.
And we all know them, right? We all have a grandmother or somebody that's, smoked 2 packs of cigarettes a day and slipped on a banana peel when she was 95 or something. But they're out there. And what we're trying to do now is, we now have a test for heart failure. When I was a resident of the insurance medical school, they say you get a blood test for heart failure, it just blew me away. I mean, you just didn't think you'd ever have one. But what we're trying to do is, we have a group of patients that we're now collecting, and while they're waiting on the transplant list, we're collecting their blood, and we're getting blood from the controls as well. And then we're trying to look at the gene expression in their blood and relate to that to what we see in the tissue, to see if we can get a blood marker for tissue destruction. So that's what we need, is a blood biomarker. And I believe there's a lot of work going on into this. Canada's just put quite a lot of money into look at biomarkers in the Long-Term Genome Canada project. And so there's a lot of effort going into that. Ideally, we're going to need a blood test that will tell us when these people have early disease, because that's when we're going to have to treat them. We're pretty confident, and we have studies to look at this and test this hypothesis, that people that are the rapid decliners, they're starting to lose their airways long before they ever lose. And there may be as many as half of their airways gone before they do lose. So there's nothing we can do to bring those airways back. Once they're gone, they're gone. So we have to find treatments that will be able to try and reverse that. And to do that, we have to have the right diagnosis, because you can't treat everybody, right? You can't just treat everybody. It'd just be way too expensive to do that. So we have to find a way to diagnose who's ill, even though they don't know it. If you really think about it, most diseases that people die from have a long preclinical course. Now, if you have lung cancer, we know the clinical history from the time the diagnosis is made till the person dies is very short. But from the first, and this has been worked out beautifully, from the first abnormal cell, first abnormal division, till you can get to something that is sort of a centimeter in diameter, that you can reliably detect. Maybe much smaller than that now with HRCT scanning, but that's a lot of radiation to detect it. That takes 20 years, 25 years to get to a level where you can diagnose it. Whereas the progress from there to where you have such a tumor burden that you can't sustain the life of the person is a very short time. And almost all of the cancers you can think of are like that. COPD is certainly like that. Atherosclerosis is certainly like that. We have tons of evidence that you begin to have the atherosclerotic streaks in your arteries when you're in your 20s. Some studies have even showed children, that were 5 and 6 years old. So that by the time those grow into a plaque that can rupture, it takes a long time. So that I think we have to get used to the idea that to get the attitude of chest physicians is very conservative. So they only want to treat somebody who's got symptoms. And there's a huge argument in the present literature about whether or not the diagnostic test that is currently used is too sensitive, and that we really should use some very much more complicated interpretation that is less sensitive. Well, from my mind, it's a useless argument, because by the time those tests are abnormal, they're already in trouble. And so that I think that's the message, really. We have to find something that will diagnose it early and find a treatment for the disease. And we never would have thought we could do that, but a lot of times it's
Is there any safe margin for the number of cigarettes smoking per day?
Pardon?
Is there any safe
No.
margin for?
No.
I mean, given all variability, but you said the healthy lungs could get rid of the.
Well, they can get rid of the particles, but the
Yes.
gases get absorbed, and there's lots of toxic gases in the cigarettes as well. And the particles are also a sink for the gases, so that they carry a lot of things in, and then if they get hydrated one thing or another, the gases can be, they can sort of function as a sink. So the cigarette is bad for us. We should all quit. Yes.
Is there any work that looks for biomarkers, not in blood but in breath? Because this is the first really that comes out
Yes.
from the lung right away.
Yeah.
Blood is filtered through all other organs.
There's a lot of work going on in that area. I'm not involved in any of it at the moment, but there's a lot of chemical analysis of the breath condensate, especially to get at the proteins. And as we get better at proteomics, the technology's all a little new. Maybe new to physicians, probably much more than it is to engineers. There probably is all kinds of spectroscopy techniques that we could use on breath condensates and stuff that might help us for early diagnosis. And there are people working on that, but I don't know of anybody that's really got a good marker in that. And that goes for anything, blood, breath, lung function, anything. It's just too hard. Yes?
Any studies that looked at subpopulations that are more likely to develop COPD and look at an early stage if there is differentiation, for example, in collagen content or something?
Well, I don't think nearly enough of that has been done. I mean, if the pollution that we have in Canada is one level. The pollution they have in places like Beijing is like up here. So that would be the obvious place to start looking. And people are starting to look in those areas and ask those questions with proteomic techniques that you can look at tissue in a more modern way. But I'm just not familiar enough with those techniques to know what's going on. Yes?
Chip, I'm always intrigued by the targeting, the loss of the respiratory bronchioles first. Why? Is it strictly the place where particle deposition is greatest, or is there, I'm thinking of it in a biological sense as a transition zone of epithelial cell subtypes, phenotypes, and their response to the inhaled toxins. Do you have any thoughts?
No, I have some thoughts, but I don't have anything that's really worthwhile. But we do know just those two things. That's the transition zone between bulk flow and diffusion. And I understand the mathematics about that area of shifting from bulk flow to diffusion can get fairly complex, and it's certainly well beyond my capabilities. But it's also the area where the epithelial cells change. I mean, the cilia are sort of upstream from there, and down there there's a different cell population. Some cells are shared, of course, across those, but many more aren't. So there's all kinds of opportunities for things to happen at that level. But I think there's just that particular one where the fact that that's where the particles are most likely to deposit is a good reason for thinking that's why the disease starts there.
And what replaces the lost respiratory bronchiole? Is there a tiny scar we can't see? Where's
Well, the terminal bronchioles and the respiratory bronchioles. The terminal bronchioles go first. The respiratory bronchioles go behind. And in emphysema, when the hole is there, when you've got a hole, there's nothing there.
Yeah.
So it just seems, it's not like you find, there's another condition called bronchiolitis obliterans, which is a terrible condition that you can get from breathing very bad particles. You know, there's a terrible disaster in India a few years ago, the Bhopal disaster, where hydrochloric acid was out into the atmosphere. People get this terrible bronchiolitis. But that's a fibrotic scar. That's a severe damage all at once that has produced an end-stage fibrotic scar. This sort of disease, people ask me, you know, I mean, the respiratory bronchioles make the centrilobular emphysematous hole. People ask me, where did the terminal bronchioles go? And I say the same place as the respiratory bronchioles. And the best we can tell, probably by a very similar process. The tissue just goes. Let's have some dinner.
Is it going on any specific target to treat this disease? I know diagnosis is important, early diagnosis to stop the progression of the disease. But those people who are suffering from this disease, can you comment on any particular target that is in the research on through which this disease can be cured? Or
What do you mean by target? Sort of a therapeutic target?
therapeutic target or
You can imagine if you have 127 gene signatures, there's a fair number that are therapeutic targets in somebody's disease or other. And I just don't think we've worked through that maze well enough to answer that question. You know, getting this JHK was a bit of a blind luck, to be frank. And I think that has been instructive in the sense that it shows that with the powerful bioinformatics tools, how you might analyze the data that we have, and you know, lots more data that I hope other people will get using the same techniques. That then that you might be able to analyze it in a way that could come up with targets. But then once you have a therapeutic target, then you have to have something that's active against that target. Then you have to go through all of the painful process of proving principle in an animal model, usually. Occasionally, if it's completely non-toxic, you can try it first in humans. But that all takes a lot of time. So it's not going to be anything that comes on the horizon quickly. I don't think.
Yes, I should take a break, especially that I would like to give you a small gift as a souvenir from Winnipeg, from EME program.
Thank you very much.
Thank you again for coming.
It's an honor.